Suicide prevention is something that's everybody's job. This is something that's happening now all across our country, and it's something that everybody has to take responsibility for every single day in conversations with people.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. On today's episode, we welcome Dr. Brian Wright, psychiatrist at Piedmont Eastside Medical Center, whose work focuses on suicide prevention, mood disorders, and psychotherapy. Dr. Wright talks with us about the rise in suicide rates across age groups, the stigma that still surrounds mental health, and practical ways we can recognize warning signs and support those in need. This episode is a reminder that mental health touches all of us, and that our support, understanding, and access to care can truly save lives. Hello, I'm here with Dr. Brian Wright. Very excited to talk to you today. Thank you for being here.
Thank you. Thank you for highlighting such an important topic.
So first question for you today is really what motivated you to study and learn about mental health and suicide awareness and prevention?
Sure. Psychiatry was my first rotation in my third year of medical school. I was a second career doctor. I'd spent the first part of my career in humanities and studied religion and worked as a clergy for several years. And when I came to psychiatry, I thought there is something about this that feels familiar. This is just helping hurting people put the pieces of their life back together.
Yeah.
And there was something about that felt way more fulfilling and enriching to me as what I wanted to do with my life than just helping people get their blood pressure and blood sugar under control. It felt deeply enriching and important work, and that was what hooked me.
That is amazing and certainly appreciated. I think we need more people like you in the field. So tell me about what the either current trends or what the I guess country or even globally is observing related to kind of suicide rates. Tell me what's happening.
Sure, suicide rates have been going up for a generation. They peaked in 2018. They declined slightly 2019 and 2020 while the pandemic was going on. And then in the post-pandemic mental health crisis, suicide rates began climbing again. In the early numbers that are coming out in 2025 say that 2024's numbers are going to be the highest that we have ever seen. Suicide rates now, there are almost 50,000 people every year that commit suicide. It is every age, it is all across the board. All those rates have been climbing consistently for an entire generation. It has become a public health crisis for every age group.
That's sad to hear that.
Yeah.
Is this something that has either seasonal trends, or you mentioned every age group is touched by this? Is this something that is more prevalent in certain age groups, or any other demographic information that you could highlight?
Well, I certainly don't want to imply that this is just something that happens with young adults. When we think about mental illness and depression, we think about the young adult mental health crisis. It is the second leading cause of death in those ages 10 to 34, but it is also the fourth leading cause of death for people aged 35 to 44. It is right behind cancer and heart disease. The highest rates of suicide are in those over 80. And so this is really something that stretches all across the spectrum. It affects men about 4 times as much as females. Females attempt suicide a lot more, but men complete suicide a lot more likely than women do. There are certain racial patterns to suicide. Native Americans have higher rates of suicide than others do, and we've seen sharp increases over the last 5 years, especially in the African American population. In those communities where mental health care is not easily accessible, or where there is stigma against getting treatment for mental illness, suicide rates have been going up consistently. There are other age groups that suicide rates have also been sharply increasing in. Veterans, for example, over the last 10 years, we've seen suicide rates outpacing national averages. People who live in rural areas who don't have access to mental health care ongoing tend to get in crisis situations, and we see suicide happening much more often. And in people with disabilities, and people who have certain occupations for some reason, things like construction jobs and people who work in factories for some reason, we've seen suicide rates going up faster than average in those populations as well.
Wow, I think that's a lot I didn't realize.
Yeah.
Is there a common thread that you think is maybe binding? I hear access is certainly a big challenge, and certainly stigma seem to be a couple of different things. Is that part of that?
Lack of access of care and pre-existing mental health conditions certainly is a risk factor, but there are a lot of people who commit suicide who don't have any history of mental illness, who for whom this is the first time. And unfortunately, there's a lot of different risk factors. It is a unique combination of health and environment and history. Um, People who have depression or substance use are much more likely to commit suicide than others are. People who are undergoing significant life stressors, such as divorce, financial loss, financial stress, the death of a spouse, kids moving out of the home, any kind of life stress situation, and then any kind of history. People who have a family history of suicide are much more likely to commit suicide than others are. Or if they've had previous attempts in the past, we know that they're at much higher risk. And so there is this complex interplay of their personal health history, of their own mental illness and substance use, their environment that they're going in, the things that happen to them in their life. And then they're also their personal history, those things they can't change, like which family they were born into and the things others around them have done.
Wow. You mentioned substance use, and I know that that means drug use as well as alcohol use. Is there? I think certainly if those are significant habitual types of things people are dealing with, that's a risk factor. Is this something even for those that are maybe even are less commonly using either different types of substances that this is an increased risk factor?
It is. It puts people in an impaired state and makes them do impulsive things that they wouldn't normally do when they're not drinking or when they're not impaired. Um, and also, those substances oftentimes contribute to their underlying mental illness, make them feel more depressed. There are certain drugs that when people are coming off of them, they crash emotionally. Methamphetamine is one of those we see in rural areas a lot. The day after people use cocaine and methamphetamine, they get terribly depressed. They often feel suicidal and hopeless. Um, when people are coming off opioids and going through withdrawal, they feel flat and anhedonic. They have no joy in their life. They just report they feel flat and nothing is triggering dopamine in their brain when they're going through that biological process of trying to reset their brain to not having that drug in it anymore. And so those things are have a biological component to them as well as just a environmental setting.
Okay. There's I think a lot to dig in here
Mhm.
that I think we'll touch a little bit on maybe stigma later. I also want to
Yep.
talk about getting help a little bit later, but I'm curious with how pervasive the risk is. What are the types of things that might be either subtle behavioral or emotional cues that someone might be struggling?
Mhm.
What are other types of warning signs that either friends, family, coworkers should keep an eye out for?
Suicide prevention is not just something that psychiatry does. You're exactly right. This is something that everybody has to be on watch for. Every pediatrician, every primary care doctor, every ER doctor, every school teacher, every guidance counselor, every parent, every friend has to learn these skills because there's just not enough psychiatrists in the world to watch out for this. This really is like after the terrorist attacks of 9/11, when the government said, you have to be the eyes and ears in the world watching for danger out there. This is one of those public health things where ordinary people have to watch out for these warning signs. And unfortunately, there is no one thing like chest pain for a heart attack that's universal to suicide. The best thing I can say to people is to say, if you see something different that raises a red flag for you, trust your gut and ask. It should be enough to initiate a conversation to say, "What's going on? Is there something that's brewing inside of you that's deeper? I've noticed you're not showering as much as you used to. I've noticed you're isolating yourself. I noticed you're not going out and doing those things that you used to do, playing basketball and running track and participating in after school activities and things. I've noticed you're not coming to social events the way that you used to. Is there something that's going on that we can talk about?" Um, there are some specific things uh, that are what I call red flags, and then there are some things that are the SOS signal. Red flags are if you see people's substance use changing, if you see their anxiety or depression changing, getting worse, if they're experiencing mood swings, if you see that they're angry or irritable, if they're experiencing isolation, those are red flags that should prompt a conversation. There's another level of warning signs that we call the SOS. These are we need to get this person help right now. And those are things like if you see a person attempting to obtain access to a lethal means, if they're trying to buy a firearm for the first time in their life in the setting of a depression, um, if you hear them talking about death, um, if you see them making any kind of plans for how their estate's going to be carried out. Sometimes people will begin asking people, if something happens to me, would you take care of my pets? They begin writing letters. Those are another level of warning sign that means a person needs to get help right away. Most of the people who attempt suicide talk about it ahead of time. Very few people get to that point, and if some of them do, that it's just an impulsive, momentary thing, but most of them have thought about it for weeks and weeks and weeks ahead of time. They're struggling with it in their mind, trying to make sense of it, and they talk about it. They drop hints, they drop cues all along the way that we have to get good at identifying. And so if you hear people talking about being a burden, this happens especially in older people. My health is so bad, I'm just a burden to my family. I'm no good here anymore. Um, the underlying tone of all those things is hopelessness. I don't see any way that this is going to get any better. Those are warning signs that people may be contemplating it.
Okay. That's great advice. So let's say I'm in this circumstance and I detect some subtle changes and I ask questions about kind of how things are going or what's going on. So if I'm lucky, someone opens up,
Mhm.
what do I do then?
Well, I think that's a big important thing that you said. Talking about suicide does not increase the incidence of suicide in people. And so you've done the right thing to open up a conversation. Just that simple act can let a person know they're not alone, that there's somebody that's there for them, there's somebody who cares about how they feel. And so sometimes just articulating it and talking about it gives them enough of a connection to not feel alone in the world. Um, if a person opens up to you and says, "Yeah, I have been really struggling and it's been really, really hard," I usually say it's something like, "It seems like you're really depressed," and they'll say, "Sure." And I'll ask, "Has it ever gotten so bad that you wished you weren't here or that you've thought about killing yourself?" If they say yes to that question, then I'll say, "Are you feeling that way right now? Is this one of those times where you're wishing you weren't here, where you can't see any way out?" If it is, the most important thing is to keep the person safe. There's no right or wrong way to do that as long as you can keep the person safe. For some people, it means that they would bring their kids home. I've seen college students who their parents would bring them home and they would just stay at home for a week or two with them to where they
Mhm.
could be around their family and be around people that loved them, and that was enough. For some people who didn't have that or whose feelings were so strong, they needed to come to the hospital. For some of them, they found something else in between that said, "If you could just come be with me for one night, I think this would pass." And so, uh, however that happens, we have to get the person to somewhere where they're safe, where they're not gonna be alone, and where they're not gonna have access to means to hurt themselves.
So it sounds like even just spending, like just being present is a way to help.
Absolutely. Um,
Okay.
reaching out and asking, sometimes just letting a person know that what happens to them matters to you is a huge, deal to somebody who's struggling and feeling alone, and It doesn't feel like they have anybody to turn to in the world.
At Piedmont, quality care changes lives. Meet Brad, a healthy former Marine who unexpectedly suffered 5 heart attacks and then heart failure. He credits Piedmont with saving his life.
The teamwork it took to provide me a path forward through a surprise heart failure and almost 5 months of intensive care in 3 different Piedmont hospitals is difficult for me to even imagine, but you guys nailed it. How do you thank someone for the gift of life?
Hear more at piedmont.org/qualitycare. Piedmont, real change lives here.
You mentioned earlier that there really is a lot of stigma around these types of conversations. So maybe you could talk a little bit about the stigma that's out there, how that may be changing or evolving, and then even how to support people that might be less likely to talk about it because of those perceptions.
Yeah. Unfortunately, mental health has some of the worst stigma in society. Addiction has terrible stigma that's associated with it. And for some way, we attached mental illness as being a type of weakness or a failure, or I'm just not strong enough. And we have to be really careful when we're talking to people who have mental illness that we're not perpetuating those type of ideas. The worst thing in the world you can do is to just do nothing, or to tell them, you know, just just pull it together. Just get yourself up off the bed, pull it together, and you're going to be okay. If they could do that, they would have done that already. Nobody makes it to me until they've tried every single possibility that they have in their emotional resources. I figure by the time they've got to me, they have probably tried everything in the world to get to me. And
Hmm.
so by the time they get to me, depression has a way of gnawing away at your inner resources and your sense of self and your self-esteem and your self-worth, and making you feel like I can't handle it. I'm out of control. I don't have any power in this situation anymore. This is bigger than me. Um, and when other people pile that on, a lot of it is internalized in people who are suffering from it, but a lot of it does come from other people too. There are particular communities that it's harder to get care in. LGBTQ plus teenagers attempt suicide at a 4 times higher rate than heterosexual teenagers, partially because they don't feel heard, they don't feel seen, they don't feel like they have any place to go to. As we said, minority communities um, attempt suicide at much higher rates because there's some stigma about receiving care, and that is not just um, the people you would think. Even people like native Alaskans, the Eskimos that live in Alaska, attempt suicide at a much higher rate. Native Americans who live on reservations attempt suicide at a much, much higher rate because they don't have access. It's not a part of their culture to receive mental health care. And so for some people, it feels to them like a tremendous failure that they can't hold their life together and be successful. What I tell people is this is not a question of good or bad or strength or weakness. It's an illness. And depression is an illness, just like diabetes is an illness, or heart disease is an illness, or Alzheimer's is an illness. That's the reason they send you to a hospital to get treatment, because this is
Sure.
a medical condition that you can't help. There is something wrong with a person's brain that causes them to get stuck in this deep depression that they can't get out of. And once they're in that condition, they can't make good decisions. And it's easy for them to get to that line where they say, the only way I can see out is ending my life.
And it sounds like just like any other type of medical condition, you need to seek treatment.
Most people end up getting some kind of treatment.
Mhm.
One of the biggest fears we have of people is being in the hospital. And we
Sure.
hear that from parents and from people who need care, is saying, I don't want to have to go to a psychiatric hospital. The overwhelming majority of people don't go to a psychiatric hospital. There's lots of outpatient care. There's therapists. Um, there's people to help you in the short term along the way. Um, and so I would always say, don't be afraid of that to let you prevent you from getting somebody care because you're afraid they're going to end up in a hospital somewhere. 3 or 4 days in a hospital may save that person's life and change the course of their future if they get help.
That's good to hear. Do you think the stigma is getting better? I know that there's a lot of public discourse about suicide prevention and mental health and prioritizing one's mental health.
Yeah.
Um, so is this something that you think is improving?
Yeah, the more we talk about it, the more normal it feels to people. And those are all wonderful things. There are a lot of athletes and a lot of big companies that have come out and uh, running commercials during the Super Bowl to take care of your mental health things. And those are wonderful to normalize that. I think there's some generational differences. Younger generations are much more open to talking about mental health concerns and mental health challenges. They have much more normalized reaching out for help and taking care of their mental illness. There's also urban and rural differences in the amounts of people that get care. People who are in urban areas have much better access to mental health care, and they're much more likely to receive care than those who are in rural areas. Over half of the counties in Georgia don't have a single therapist or a psychiatrist in those counties. And so
Wow.
if you live in a county where there's not a psychiatrist for 100 miles from you, the chance of you getting mental health care when you need it are pretty low. And so there's a lot of barriers like that that we still need to improve on, helping people with the stigma of that, but also increasing access to people.
Okay. Thank you for that. So, what resources or tools do you recommend? It sounds like there's in some cases people have access to experts like you or access to facilities like the one that you work in with a variety of programs. In other cases, it's pretty far stretched and pretty limited access. So what's out there?
The biggest resource that we have here in the state of Georgia is available nationwide. Georgia has a 988, that's the National Suicide and Crisis Lifeline. It's just like 911 if you have another emergency. You can call 988, and it's a mental health crisis line that's available anywhere in the state. You can talk to a person 24 hours a day, 7 days a week. If needed, they'll even send a person out to your house to do an evaluation to see if you need to come into the hospital. And then if they determine that you need to come somewhere safe to be in a higher level of care, they'll make the arrangements to come out and transport you to the local emergency room. Um, if you don't feel comfortable doing that, there's always somebody that you can talk to with your local doctor. I tell people in rural areas, if you don't have access to a counselor or a psychiatrist, start with your local primary care doctor. That doctor's known you for a long time. You can go to them and say, "Hey, I'm not feeling myself lately. I'm feeling down. I'm starting to have these thoughts that I don't understand. They feel like they're taking over my life." That's a good person to talk to. If that doesn't work, if it gets to an emergency setting, you can always go to a local emergency room. You can walk in any emergency room anywhere in the state of Georgia, even if they don't have a mental health treatment facility, and they will transport you and get you expedited to where there are specialists who can take care of you.
That's a lot of good options. And it sounds like there's something for everybody in the state, which is pretty neat. So your background in theology leading into psychiatry is really interesting, and just curious if you could either comment on any relationship between what you've learned from theology or one's system of belief and how that may impact suicide prevention and or suicidal ideation, if there is any relationship there at all.
I think doing both has made me better at both. Studying theology has made me better at doing the work I do in mental health. And I think studying mental health has probably made me better at understanding theology and those ultimate questions. There is a lot of overlap. For a long time, religion was the main treaters of mental illness. Up until the last 120 years, it was people in religion who were taking care of those who had mental illness and were institutionalized. And so, beginning with Sigmund Freud 100 years ago, science got very skeptical of religion and even thought religion caused a lot of mental illness.
Hmm.
And so, the last 100 years, there's been some separation between the two. I will say that specifically related to suicide, for those people who are contemplating the end of their life, a lot of them are thinking about ultimate kinds of questions about what my life's going to be like after I leave this place and when I close my eyes, not to waken awaken anymore?
Mhm.
And those questions are on their mind. And for many of them, their faith and their religion is the protective factor that keeps them from committing suicide. I've heard a lot of people when I practiced outpatient who came to me and said, I've been contemplating suicide, but I have faith and I know that I'm not supposed to do that. And that's what prevents them from moving into an area that they wouldn't. I think at their core and at their best, um, psychiatry and the work that I did in my first career and church work are both healing works. They both deal with mystery and invisible kinds of things, inner work, that there's not blood tests and there's not
Mhm.
x-rays and there's not a tangible, how do you measure depression or anxiety or hopelessness or anhedonia? Um, and so they deal having some experience in talking about purpose and meaning and self-worth probably helps a lot in what I was doing now because I have a lot of those same kinds of questions.
Yeah, that's great. So I can imagine that providing support for people that are struggling with mental health is also challenging. How do professionals themselves work through dealing with such challenging topics?
I will say that finding your work meaningful and believing that what you do really makes a difference in the world is the most energizing and fulfilling and healing thing to me in the world. If I didn't believe that what I was doing made a difference in the world, this would seem like just drudgery. But I get to see the impact of what I do every single day. When students work with me, we stopped teaching them medicines and diagnosis. They read books and get that kind of stuff. What we started
Mhm.
doing here is showing them, letting people tell their stories. So I take them to patients and I say, tell my student what depression is like when you're suffering with it in your life. Tell them how crippling OCD is. Tell them what it's like when you don't have any desire to get out of bed. And then for the students to get to see them get better and how their life changes in such a short amount of time opens up this whole new excitement about medicine again for people to say, this is why we all came to medicine because we wanted to help make people's lives better. And when you can find a little slice where you really get to do that, where you can see people walk in and then 5 to 7 days later walk out an entirely different person with a whole new outlook on life, that's the most rewarding thing in the world.
That's fantastic that you've been able to see people feel better after just 5 to 7 days. Is that how typical is that, or what would someone expect if they're really struggling and they start to engage in professional help? How
Sure.
quickly would they start to notice some improvement? I don't even know if that's a fair question to ask, but
You know, in psychiatry, we have that conversation a lot, and there's a lot of debate about that. How much of this is placebo effect, and how much of this is actually due to medication, and how much of this is just being in a loving, nurturing, caring environment in a hospital setting. One of my professors used to call it reactive hopefulness, and he said the very act of just reaching out and trying to get help does in fact help. It's sort of like when you make a healthy habit, if you start eating better, it's a lot easier to exercise and do all those other healthy things. You do
Mhm.
feel better when you start the ball rolling. And so just reaching out and asking for help begins this psychological cascade that really does make you feel better. I'm being proactive about my mental health. I'm asking for help. I'm taking medications for the first time. I'm seeking to engage in therapy and work on some of the issues that I haven't. And it really does change people's lives when they reach out for help. Just the fact of reaching out for help sometimes often starts that ball rolling.
Would you talk a little bit about the the role or the impact of sleep, sunlight, activity, those types of things in either suicide prevention or helping individuals that are dealing with depression or other mood disorders?
Sure. We deal with that question a lot in outpatient setting. What's the non-pharmacological things that I can do to help my depression? And all those things you mentioned are wonderfully effective. They have great evidence behind them. Exercising 2 to 3 times per week boosts your mood, and over the course of a year is just about as effective as any kind of medication. Getting a good night's sleep, eating Wright, all those things are little small slices of the pie that help your mood. Um, People take multivitamins. There's some supplements that people have found that help with their mood as well. Those things are great for mild to moderate depression for people who are not in any sort of safety concern. All those are wonderful things to do. When people get to the level where they don't feel safe to be at home, they need a little bit higher level of care or something that works a little bit faster to get them back on the right track. But all those
Okay.
things are wonderful. Getting a good night's sleep, eating good. We tell every college student that, if you just eat good, get a good night's sleep, get 8 hours of sleep, you're going to be amazed at how much more optimistic and hopeful you feel about the future.
Well, thank you for that. I am going to ask you a final question, but just want to acknowledge how grateful I am to know that there are clinicians like you that are really passionate about helping improve mental health for our communities and thinking about ways that we can extend access and reach. So just want to say thank you for what you do and really say that you're an inspiration. I think just hearing your approach and passion towards this improvement is really, really awesome. The last question I have for you is really what would you like to leave what message do you have for our audience?
Mental health affects everybody. It affects people who are just beginning their life all the way to people who are in the last days of their life. It is not something that any of us are immune from. Um, People can have life situations happen to them that are none of their control, and they can cause us all to have to suffer. So when we fight and we advocate for mental health care, it's not something that we're fighting for somebody else. It's something that we all are going to need somewhere along the way in our life. We need to know that there's somebody there to listen, to help, to care, and to walk with us through those dark places in our life. And so that's what the fight for mental health care is really about. It's so that when you need it, when your kids need it, when your parents need it, when your neighbors need it, there's access and there's some place for them to go.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.